Good afternoon, everyone, and thanks so much for joining us for our webinar, An Introduction to the Primary Health Information Platform, presented to us by Daniel Belshaw. We'll just start now with an acknowledgement of country. The Western New South Wales Primary Health Network acknowledges that we work on the traditional lands of many Aboriginal clans, tribes and nations. I'd like to pay respect to elders past, present and emerging, and acknowledge the traditional custodians who care for this land on which we work and live. I acknowledge and respect their continuing culture and the contribution they make to the life of the communities in our region. The webinar this afternoon is being recorded and we'll make that available for viewing on our website. And there's the address there. So that should be available by tomorrow afternoon if you want to watch it again or get called out during the session this arvo. So after the webinar, we'll send out a link to a survey, and we'd really appreciate it if you can complete that for your feedback for further sessions. If you can't see the control panel, just click on the small orange arrow, which is usually at the top right-hand side of your screen, and that should open up the bigger screen there down the bottom. Everyone's in listen-only mode to optimise the sound quality. So if you've got a question, please use the questions box and Daniel will respond as we progress through the webinar. Click on the triangle next to the questions box there and type your questions in, and we'll feed those through to Daniel as we go through. So I'll just hand over to Daniel now to start.
Good afternoon, everyone. How are you all? So thank you for joining us and taking the time to have a look at the Primary Health Information Platform. Over the last 10 months, the Primary Health Network has undertaken 2 phases of upgrading the Primary Health Information Platform, and I'm going to be stepping you through each of those 2 phases of the changes today. The first phase of this was the PIP QI reporting. So I'm just going to dive in now. And the 10 PIP QI measures that we have for the Commonwealth reporting to the Australian Institute of Health and Welfare are all located here. And you can also see them overall as an overall screen here for you. If you're wanting to, for the purposes of educational within your practice as well, you can actually want to take a quick snapshot. You can actually click the print button here, and you'll actually be able to print each of the overall pages. And it will show you the snapshot of each of the indicators and how your practice is reporting in for each of those. So you do have that option for the purposes of doing that for internal quality discussions. So before I dive in here for the very first measure, which is the HbA1c in the last 12 months for anyone with type 1 or type 2 diabetes, I'm just going to show you how it's going to look on your screen first, because the screen that I'm showing you is showing you data across all of Western New South Wales Primary Health Network. And so, for example, across the entire network, you can see here, for example, that for this particular measure, which is those patients having that HbA1c in the last 12 months, just under 50% of patients that have been identified with diabetes have had that. But how it will look for you looking at this is this. You get an additional indicator here called a cohort average. And so what the cohort is a grouping of similar practices that have a similar number of active patients. And those active patients are patients that have visited the practice at least 3 times in the last 2 years, which is the Royal Australian College of General Practice guidelines. And so, as you can see here on this page, every single time that you want to look at your own practice, you're going to be purple. And so you can see how the practice here, for example, has performed against this indicator versus their cohort. You also get the raw number down here. So for this practice, it's 124 patients versus the average of the cohort of 99 patients. And you can also see how your cohort looks here spread across and where your practice specifically is sitting in that. And so you can slide along and actually see how you're comparing against each of those ones as a percentage as well. So for what we can see here across the PHN, we just get the general numbers here. So we don't have anyone that we compare ourselves to, which is why we don't have the cohort average here. The next step that we have down here is how the indicator looks by Aboriginality. So one of the things that I know our practice support officers have been looking at is trying to work on strategies to ensure that we're getting really good compliance with all patients registering their Aboriginality. And as you can see here, for those patients that have type 2 diabetes where they've been identified as Aboriginal, 48% of those have had a HbA1c in the last 12 months. Whereas here we can see that for the population that have type 2 diabetes where we know that they're non-Aboriginal, 48% of them have had a HbA1c in the last 12 months. And finally, where we don't have a status recorded at all, this is the proportion of those patients that have had HbA1c over the last 12 months. So I might just pause there and see if there's any questions for anyone, if they're a little confused about that concept there about how to interpret this particular step.
Nothing coming through yet, Daniel. If anyone's got any questions about that step, just type it in the questions box there.
Thanks so very much. So how that will look at the practice level is you'll also see how you're comparing with the cohort. So you'll get the proportion for the individual practice, and you'll also get that cohort comparison. And again, you'll get to see for each of those indicators exactly where you're sitting within that cohort. So ideally, I guess for a measure like this, you'd be wanting to achieve 100% for both all of your Aboriginal and non-Aboriginal patients. And in theory, you'd be wanting this to be 0. So in theory, having no patients that have no Aboriginality recorded at all. And finally, the third different set of data that you can see for this particular indicator at a practice level is how you've progressed over time. So for example, as a part of the quality improvement program, if yourself and your team at your practice desire to put an intervention and you want to see how you're progressing with that change. So for example, if you sit down and pull out all the patients that haven't had a HbA1c in the last 12 months and you start booking them to come in to visit you in your practice and you want to see if you are getting that uptake, you will be able to see over time that that's occurring. And for example, across the PHN, we are seeing a steady increase in the number of patients, and particularly an increase there in the last month of patients that have got their HbA1cs being recorded. And again, you get that breakdown by Aboriginality as well. And then finally, this is what you're going to see. And remember at the beginning, I said that your practice is always going to be purple and your cohort is always going to be pink. So for example, in this example, you've got a cohort that's reporting below the particular practice. And so you can see that this particular practice for the point here in January have 40% of their patients or just over 40% of their patients that have had a HbA1c recorded versus 31% in their cohort. And you get that breakdown again by cohort for Aboriginality as well. So that's how you would interpret each of those individual indicators. And so what we do have here on the PIP QI module is we have the next other indicator. And some of these indicators that you'll start noticing are specifically about the clinical management of a patient, or they're about the process of the management of the patient. So for example, something where practices can really focus on is the proportion of those patients with a smoking status recorded. It's interesting to note that the criteria here set by the Commonwealth is the smoking status recorded itself, which is the process, not the proportion of patients that are smokers or non-smokers, for example. And so again, you can look at the breakdown across the PHN, which is both Western and Far West local health districts, that about only 16% of our patients have got that recorded. And again, when we're looking at by Aboriginality, if we're asking those questions as well, and the change over time across the PHN with getting that data recorded. The next process of the indicators that we have here is those that have had a BMI recorded. And we're doing actually quite well across the PHN here, just shy of 2/3 of our patients having that question and having that data indicated being put into the system. And a lot of the times, it might be that it's not the fact that a practice isn't asking the question and recording the data. It may not be being recorded in the correct location to be picked up by the system. So if you do have any concerns or queries about what you believe is your data in here, again, please contact your practice support officer and have that conversation. We've been able to work with practices in the past to improve the cleaning of their data in particular to better reflect what they're practically doing and clinically doing with their patient management. The next indicator we have here again is another process one, which is the proportion of those patients aged 65 years and over that have been immunised for influenza. You'll note that this is in the previous 15 months. So this is something that's going to be a moving indicator. So you'll note here where we've got the reporting month, you can pull down and you can look back at the last 6 months of your reports. And you'll notice that indicator is always going to vary over time because it's moving. So you would expect to see around, for example, in March, February, April, that's probably going to be a much lower number because of the 15-month lag there with influenza seasons. So it's just something to be conscious of with some of these indicators, is that when there's a specific timing limit to it, that it will move every single month. Whereas when something is a bit static, is have you recorded this, yes or no, they won't move as rapidly. And again, you can see across the PHN that over 2/3 of our patients that meet that criteria are being immunised. Again, we also need to note that not every patient gets immunised in general practice. So this is only going to be recording those that are being registered in their general practice software as being immunised. So if someone goes to the pharmacy and they haven't told their doctor, that's not going to be recorded. But if a doctor is aware of that, they are able to still record that in their software, so it can be included in this as well. So again, they're really good conversations to be having with your practice support officer. The next indicator that we have here is for immunization. So this is obviously specific to those patients with diabetes. And again, that's more about the clinical guidelines and how we're achieving that across the PHN as well. And again, we're looking at over 6 in every 10 patients that have diabetes being immunized. So there are some really good achievements. That's not as high across Australia, and that's something that obviously we need to be working on as well moving forward. Like the immunisation for diabetes, we also have it broken down by COPD as well, which is the next indicator. You'll note here that that's for anyone that's aged over 15 years and over. So that's a specific metric that's been applied by the AIHW. So some of these indicators will be age specific and others will be time specific here, or they will be both. And in this instance, anyone who is over 15 obviously would meet the requirements of having chronic obstructionary pulmonary disease. And again, you can see how the different practices are rating across the organizer PHN. So there's one practice where we've got 88% of patients being noted in the system. And we can go down here to where it is 26% in one of the practices. And again, that's where we can really have that conversation about the quality of the data, or how the practice support officers can be helping your practices, particularly your practice managers, for example, going into PATCAT and pulling out patients that may have missed their influenza vaccine and actually being able to get those patients into your practice as well. The next one we have here again is another process one, which is specific to age, which is 15 years and over. So those that have got their alcohol consumption status recorded. Again, it's only about it being recorded, not is it safe consumption or not. And then finally, the last couple that we have here is specific, again, to ages. Here, 45 to 74 or 35 to 74, if you're Indigenous, of those patients that have had a CVD assessment undertaken. So again, you can see there's lots of variability across our region for practices being able to, get their patients on board to have these assessments undertaken. and hoping moving forward that, we're really able to have our practice support officers working with practices for their quality improvement programs. Finally, we do have here the HPV. Now, this is a different metric to what was previously reported on the Primary Health Information Platform. We previously had an indicator that looked on the last time someone had a pap smear. We've moved specifically, obviously, with the PIP QI measure to moving to the blood test as opposed to the pap smear now. So that's a change. And again, we do note that obviously a lot of women will not be having this undertaken through general practice, particularly in smaller towns. It may be that they might be going to Family Planning New South Wales or another provider, so you may not always be able to actually capture that data. And again, that's where obviously maybe having the doctor or the practice manager or the practice nurse having that conversation with a patient that meets that criteria and just asking in the last 5 years if they've had that checkup or not. And last but not least, we've got the process of those with diabetes in the last 6 months as opposed to the others, which are 12 or 15, having their blood pressure recorded. And again, by and large, we can see that across the PHN and across the practices, we can see we're getting some very good rates there, of over 6 out of every 10 patients coming in and having that tested every 10 months. So I might just pause there at this point about the 10 PIP QI measures if there's any questions about that at all.
We don't have anything through yet, Daniel.
No worries. I'm hoping I'm not losing anyone at this point. I should also note that when you actually dive into the lower sections, you can also print these out as well. So at each level, you can print them out, and at each level and each indicator, you will be able to look back for 6 months. And if you do go back to 6 months, for example, so if we're looking at May, you're actually going back to May 2019. So you can go back almost as far as 18 months if you really wanted when looking at change with these indicators moving forward as a part of your quality improvement programs. So that was the phase 1 update that the data team at the Primary Health Network undertook. The second phase of the update was to actually update the indicators in the bulk of the program, which is where we've got our population health and screening questions and our chronic disease and mental health modules as well. And for this process, we undertook quite a bit of consultations through the practice support officers. Many of them may have had conversations with those attending today about the things that they enjoyed about Primary Health Information Platform and the problems or the indicators they felt that were missing. We worked with the general practitioner who is our advisor to the PHN, and we went through each of the clinical guidelines that are recognised in Australia. So for example, the Kidney and Heart Foundation guidelines. And we also took a positive epidemiological approach to how we actually looked at delivering these modules and specifically these indicators moving forward. And I'm just going to dive in quickly to the population health one.
Just before you start, Daniel, we do have a question through from Karen.
Yeah. Oh, absolutely, yes. Hello, Karen.
So with alcohol, sorry.
Yeah.
Sorry, with alcohol, if you freehand that they are social drinkers or only drink once a month, will that be added to the count?
It will, because this metric here is about the proportion of those that have got their status recorded. It's not about how much they're consuming to drink. So again, that's a really important difference between a process and an outcome. So a lot of the measures that the Commonwealth have here that we're reporting to the Australian Institute of Health Welfare are really about those processes being undertaken in the patient management and the aim of looking at quality improvement in achieving better clinical management in these areas that the Commonwealth Department have identified, and that's kind of the background behind that. Has that kind of assisted your answer there, Karen?
And that's a yes, thanks from Karen.
Oh,
Thanks,
fabulous. Glad to help there, Karen. And please, anyone, if you do have any questions, please feel free. I really want this to be very interactive, and I really want everyone to walk away from it going, I think I know how to use this. So please make sure those questions come forward. So we have our population health and screening module here. And as you can see, we can look at the active patients that are accessing the aggregate practices that we have data sharing agreements. And this is where you can really see where I'm talking about that difference between a process and an outcome. So for example, having that question asked, is someone Aboriginal and or Torres Strait Islander? Across our PHN, 87.3% of active patients have been asked that question, which is really good. And I think that's obviously some really great work that practices have undertaken to really ask that question. So again, speaks positively also about our cultural safety in this, across our region too. And that's where the next indicator kind of helps here, as you can see that the proportion of patients that are Aboriginals that are accessing services that are active make up the active population is roughly the same that makes up the population of our region, which is roughly 11%. So to me, that's a really positive indicator. And I'm sure if we were to dive down here, for example, there'll be a lot of variation between practices, but you can see there are a lot here that are 100, 90%. And where some practices may be struggling, it's really in the 50% here. But by and large, there's some really great work that's happened in this space. Look at that, over 90 there, all the way there. So that's a lot of the patients who have asked that question.
We do have another question from Karen,
Yep.
if that's all right, Daniel.
Yeah, absolutely.
If you do a weight and a height and it automatically adds BMI, is that recorded as well?
Yes, it is. So you'll see here, I'll scroll down here, Karen. I hope no one minds if we jump ahead a little bit. So this also goes back to the changes that we've made. So previously we had the process as someone had the BMI recorded. So what that means is if someone is an active patient and we've got a height and a weight entered in the last 2 years, then they'll be picked up and they'll be included in that percentage. And so then what we're wanting to achieve as a positive long-term health outcome across our region is patients with a healthy BMI. So this is the outcome, and so this is a new indicator. We've also got the new indicator here about the waist circumference being asked in the last 2 years. And again, those based on gender of 94 centimeters for males and 80 centimeters for females that have a healthy waist circumference across the region. When talking at a couple of the PHN's clinical councils, one of the physicians that was there had mentioned that they felt a bit uncomfortable sometimes about, putting a tape measure around a patient, and then another clinician had said, oh, I just get the patient to do it themselves and they just tell me what it is and I record it in the system. So there can be innovative ways in which we can make sure that we're capturing that data. But what we have done is we've traditionally had just the one indicator. We've now put the outcome that we're wanting to achieve, and we've also added another process and the other outcome as well, so we're getting a much more complete picture. So I'm hoping that helps out there, Karen, and I hope it really also adds to conversations at your practice moving forward as well.
Just got a comment, a reminder from Fallon as well. So that free texting won't go through for any reporting, so always make sure things are clinically coded.
So that's why you need your PSOs around, everyone, because they know this amazing stuff. So if in doubt, always engage with them. Thank you for that, Fallon. One of our new measures here, for example, is the proportion of patients that have their allergy status recorded. So this was feedback that people wanted to make sure that they could be checking in with their patients and having their allergies recorded. And again, you can see by and large, we've got really strong recording of that indicator across the PHN. And there's probably a couple where we can provide a bit more support in making sure it's captured appropriately moving forward. But that's an example of, again, another positive indicator that we've put in. Again, we've had the process traditionally of smoking status being recorded. Please note that this is very different to what the Commonwealth has as a criteria. It is not the same. The age is different and the timing is different. So they're very different numbers. We've had a bit of a problem with this one. And unfortunately, it just is that difference between the Commonwealth. And the reason why we've got it listed here as 10 is because obviously we recognise in some communities, children can be taking up smoking from that young of an age. So it is always important to be asking. And yes, it is a bit different than the Commonwealth, but just noting that that's what the situation is here. But you'll see here, the recording of the smoking, and then again, that achievement is, well, what's the proportion of the patients that are coming in that have never smoked and those that have previously been smokers? Again, originally we had, that alcohol status being recorded, and now we've got here, going back to your point, Karen, is safe alcohol consumption. So the proportion of those patients that, you know, have been noted as having 2 or fewer standard drinks a day. So again, that's the positive health outcome that we're wanting to achieve. We've discussed the BMIs, and again, we've got the blood pressure recorded, which was the old process that was in here. We've now got the outcome that we're wanting to achieve, which is that blood pressure of below of 140/90 or less. So we've added that in. And again, this is different. It is than the past 2 years, whereas the Commonwealth PIP QI is for those patients with diabetes in the last 6 months. So that's very different than that one. So it's something to be conscious of as well. And again, the cardiovascular disease, we've just got it as 45 or older or 35 or older. We haven't got a lower limit on that. So then again, that's got a bit of a different proportion. Fecal occult blood test has been included to again support the screening for cancer. We acknowledge that a lot of patients probably will not be informing their general practitioners if they've participated in the mailing program or not. But again, it is probably just that point about having that good question so we can better capture that data and better support yourselves as clinicians and practice managers in understanding, you know, the health of your active patients at your practice. Again, we've got the process here of those that have had the mammogram, acknowledging that a lot of the times that can be done through the local health district, and they're not always the best with producing letters and feeding those back to general practitioners. But again, it is worthwhile for anyone that's 50 to 74 having that conversation about have they had a mammogram in the last 2 years and recording that as a yes. We've got the cervical screening that does match what is in the AHW. And again, the childhood immunisation, acknowledging that most children do not have their immunisations undertaken at general practice. But again, just asking that question of patients and making sure that you tick that box in the data capturing. And finally, we've got the pneumococcal vaccination by Aboriginality here. So for those that are 65 and over and those that are 50 and over and Aboriginal, which again is based on clinical best practice.
Sorry, Daniel, a comment from Karen that for mammograms, the best practice software doesn't have any tick boxes for that.
That's probably one of the limitations and that we'll have with it. So again, because every practice uses different software, I'll record that down and we'll look at what we can do moving forward, Karen, but I can't promise anything. But we are cognizant that...
Sorry, or for
they
the
don't
FOB
have that either.
No.
Okay, so mammogram or FOB T. Yep. Thanks for that, Karen. And as I was saying before, we've got the difference in the pneumococcal vaccine, and again, the influenza vaccine, we've got the herpes zoster, and then finally the Aboriginal health assessments in the last 12 months, so that's 715 billing, or if there are other billing opportunities for health assessments that have been undertaken. So this is just the general population health and screening module, just to give you an update from a practice perspective of the health of the patients that are visiting your practice overall, as opposed to looking at them individually, and also to see how you're going with the screening for those specific cancers and other chronic diseases as well.
We've just had Michelle Drewler's add in that she can provide some support to the process, because you can record mammograms in both best practice and medical director software. So Michelle might be a good point of contact.
This is the beauty of these sorts of webinars, isn't it? We can always help each other out. So thank you so much for that, Michelle. And please, Karen, touch base with either Michelle directly if you know her, or with your peers, so that we can help you with that. And anyone else who's listening with best practice that isn't sure about how that's captured as well, because we really want to support you as much as possible to make sure that you've got a really good idea about the health and well-being of the patients that make up your practice. I'm now going to dive into the diabetes one, because this one's had significant change. Again, really moving towards the outcome, because the very first iteration of the Primary Health Information Platform had very much those specific measures about processes being undertaken. So as you can see here in the overall page for the diabetes module, we've got the proportion of those patients that are coded as having type 2 diabetes. So for all of our active patients, it's about 6%, which is higher than the Australian average. but I don't think that would be particularly surprising to anyone sitting here today. The next step that we have here is obviously that BMI being recorded in the last 2 years, and critically for those patients with type 2 diabetes, those with type 2 diabetes that have had their BMI recorded and is in a healthy range. And again, you can see there's a lot of variation across the region for that. And you can see how it can also change over time. So we've been fairly stable over the period with the proportion of patients that meet that criteria. But it's one of the angles that we really, and when I was saying earlier about that epidemiological population health approach, we're really trying to take a very positive approach and linking this back to the health needs assessment, which the Primary Healthcare Network undertakes every few years in partnership with the local health districts. And again, obviously, for the alert aspect, for particularly really useful for practice managers and general practitioners, is looking at those patients with type 2 diabetes that are overweight or obese, so those that have got a BMI of 30 or more, which is just under 50% of those. So again, being able to sit down with your PSO, sitting in PATCAP, pulling out those lists for those patients, and then making sure that, you can look, for example, if you have access to the CDMP program, how you can link these people into dietitians, for example, or how best you can have those conversations about better management through what's available through MBS billing. Again, we've got the smoking status recorded for those with type 2 diabetes, those that have never smoked. We've also got the alcohol consumption for those with type 2 diabetes and those that have got safe alcohol consumption. So again, the positive behaviour. The HbA1c being recorded in the last 12 months. Those patients living with type 2 diabetes that have HbA1c of 7 or less. So obviously that clinical achievement that we're wanting the patient to aim for. And again, looking at those where it's greater than 8 as the next indicator. The process here for cholesterol being recorded in the last 12 months and those that have a total cholesterol of 4 or less in the last 12 months. So again, what we're wanting to achieve out of undertaking that process with the patient. And then finally, we've got the blood pressure, and we've split this out, and pardon me if I mispronounce this, we've split this out based if a patient has albuminuria or not, and obviously the difference between male and females, which we've listed there. Obviously of 2.5 milligrams per mole or 3.5 milligrams per mole. And again, when albuminuria is present, we've got that different definition there as well. And you can note here that the blood pressure changes to 130/80. So acknowledging that when a patient has this type of stress on their kidneys, that we're wanting to get that lower blood pressure, as a part of that better management of those patients. Next, we have obviously if the ACR has been recorded and those that have a normal ACR, again, looking at the difference by gender of 3.5 for women and less than 2.5 for men. And we've got the estimated glomerular filtration rates, those that are normal. Those patients with diabetes, again, that positive clinical management of those that have had an immunization for influenza in the last calendar year. You note that here that this is calendar year as opposed to the last 15 months. So again, that is different from the PIP QI measure because it's also looking at a different thing. Because if you're looking at your patient and you're thinking calendar years, you're going to be asking, have you been, and most patients are going to think of, well, I had it this year or last year, for example. So there will be differences in how you interpret that. And finally, again, acknowledging that a lot of doctors themselves don't do the foot or the eye exams, but you can also go into the system and record these if your patients have had an eye exam in the last 2 years or if they've had a foot exam in the last 12 months. So these have also been added as new features to this module as well. So I'll just stop there before we move to the next one.
No other questions have come through just for the minute. Oh,
thank you.
Yep. I just said that, and we do have one that's come through. So one
awesome.
from Gillian. Is there a period of time
Gillian.
between foot checks?
Yes, so the metric there for the foot check is if someone's had it every 12 months. And we consulted with a number of AMSs on that one because that was these two indicators here, the foot check and the eye check, was something they clearly saw as a key priority for them. And the guidelines, particularly for Aboriginal people with type 2 diabetes, is the 24 months for eye and 12 months for the foot. Does that answer your question, Gillian?
Sorry, is it still high risk foot checks twice a year?
The guidelines that we had was that it was at least once a year that it was to be undertaken, but I guess it would be a clinical decision if you felt someone was high risk enough that they needed it. But again, that would be clinically indicative of how it looked in the last 6 months based on that check. But the generic guideline is for it to be once a year.
Thank you, from Gillian.
No worries. Any other questions from anyone before we dive into the next module?
I think
No
we're right to move
worries.
on.
Thanks so much, guys. I hope I'm not moving too fast. I really want everyone just to feel really comfortable with this. The next one that we'll be looking at here will be the cardiovascular module. And here you'll see with the cardiovascular one, we've got those with patients that are diagnosed as being coded with cardiovascular disease across the PHN. So, a little over 6% of our patients being identified. Those of which have had a BMI in the last 2 years. Again, that was the process. This was previously there, whereas the next two, like the diabetes, which is the BMI being in target, and those that are overweight or obese, these have been added because obviously they're the outcomes we're wanting to achieve. And this is the outcome so that, again, practice managers and general practitioners can look at their patients on a population level and then sit with their PSOs and work out which patients they need to work with. Again, and linking with other allied services. Really good with the smoking recording, and then obviously the proportion of those with CVD that have never smoked. Likewise with diabetes, we've got the alcohol and CVD and the safe consumption of alcohol, and the cholesterol and the safe cholesterol level of less than 4. The blood pressure finally, and again, you'll note here with those patients with CVD, the blood pressure has changed to 130/80 in the last 12 months, as opposed to 140/90, which you would have noticed in the population health module in particular. So this is just, again, to support practitioners and practice managers and looking at their patients at a cardiovascular level and where they can be looking and where they can support. So how does everyone feel with those particular indicators?
We've had nothing come through, Daniel, so looks good.
No worries. It is very similar to diabetes, and again, that was based on a lot of the guidelines and what we're wanting to achieve with the patient management. The respiratory KPIs modules that we have here, we've provided a bit more depth for you as well, so you can look at the proportion of those patients in your practice that have asthma, those that have been diagnosed as having COPD, those with asthma and or COPD with a smoking status recorded, and those with asthma and or COPD that have never smoked. And finally, also those that have got asthma or COPD that have had their spirometry recorded in the last 2 years. You can also see here that both populations are at high risk for influenza and pneumococcal, so we've provided you with a breakdown of those that have had the vaccine in the last calendar year. Again, that's very similar to the diabetes one. And again, that's based on the clinical practice and the way that you generally would have patients thinking about that question as well. So in raw numbers, you can see across the PHN that this calendar year, those with asthma, 10,000 of them have been immunised for influenza. We've also got the influenza vaccine and the pneumococcal vaccine for those with COPD as well. So you can see that obviously those patients with COPD, we've done very well across our region in making sure those patients have got their vaccines in the last 12 months for pneumococcal. So again, that's primarily about looking at what cohort your patients are, looking at the key risk factor for these patients, which is obviously having their smoking and their spirometry checked. And finally, because they are at high risk, acknowledging that these patients should be or from a clinical level, we should be having those conversations about their pneumococcal and influenza vaccines. So that's kind of the general focus that we've had here for the respiratory one, acknowledging that particularly with PAC-CAT, there's very limited variables that we could use here where we could add any further depth, unfortunately. So does anyone have any questions about the respiratory module?
Nothing there yet, Daniel?
Fabulous. Got a couple more to go through, everyone. So the next one we have here is our mental health one, and we've made a few critical changes here to mental health because previously the mental health one was very generic about if someone had had a mental health plan in the last 12 months and if they had had a mental health condition or if they had more than one mental health condition, and that was really about it. And again, with the consultation process, one of the things that really came out was that ability to have that conversation with someone that is suffering a mental health condition, and also being cognizant that they may also be at higher risk of chronic diseases. So what we've done here is, again, this is based on what is reported in your systems, is the proportion of those that have got a coded mental health condition and those with a mental health condition and where a BMI has been recorded. And you'll see that looks vastly different compared to the chronic diseases. So that's probably more of a reflection that a lot of the times we're focusing on the mental health aspect of a patient and not always thinking about having that conversation, or the fact that we're focused on mental health when we're not prepared, we're not feeling comfortable to have the conversation about the chronic disease risk factors. So you can kind of see here, for example, where when we're not across the PHN being as consistent with asking about BMI with those patients that do have a mental health condition. And you can see here of those with a mental health condition where their BMI is healthy. We've only added here, again, trying to think in the mental health space, specifically the positive outcome. So you'll note here that unlike diabetes or CVD, we don't have the negative or the high aspect here, which would be overweight or obese BMI, because it's specifically about the outcome that we're wanting to achieve clinically. You'll note here blood pressure and those that have got a blood pressure that's greater than 140/90 in the last 2 years with mental health. And again, those with smoking recorded, that's actually pretty good and fairly consistent, but then those that have never smoked, which is ideally what we're wanting to achieve, and those that have got a mental health plan set up. And that's obviously based on MBS reporting. So again, if you're not coding correctly with the MBS, you may not be capturing that in the data. So you may have those plans with your patients, but if they're not recorded, we may be missing them. So again, have that conversation with your PSO if you've got any doubt about the data at all. So that's the very brief look at the mental health module. Is there any questions about that one?
No questions as yet.
No worries. I hope I'm not rushing too much for everyone. So a completely new module that has come about with the phase 2 is the aged care module. And we did consult with our aged care team within the PHN and also our GP advisor and our PSOs around this. And so what you'll notice here is that this is a bit different where we have broken the data by Aboriginality because they are very different groups. So you'll note here that we've got the proportion of the patients that are active patients across the PHN that are 50 or over that are Aboriginal or Torres Strait Islander. 23% of your Aboriginal patients meet that criteria. And of those, you can see those that you've got listed as having dementia, and those that have been coded or listed as having osteoporosis. Next we've got here is the polypharmacy use of 5 or more or 8 or more medications. So again, from a quality improvement perspective, that's just more to provide general practitioners and practice nurses, for example, with a population snapshot, so that if you do want to dive in deeper, then you can sit with the PSOs and have a look at that data if you're wanting to on your patients and their medication lists. Because sometimes, particularly if you've got busy practices and you've got more than one doctor coming in, you may not always know and be quite aware of all the different medications that a patient is on. So that's why we've got the two different criteria there of 5 and 8. You'll also notice that we've got the non-Aboriginal population here, which is 65 years and over. And again, those with dementia and those with osteoporosis, and the 5 and the 8 polypharmacy use as well. And you can again see here that you can get, very different variation across the PHN with the polypharmacy use. And obviously that's very much a clinical indicator. And so that's just more of an indicator here so that clinicians can be, looking at it from a population perspective as opposed to looking at it an individual patient perspective.
Daniel, we've just got a comment from Karen that the aged care and the other couple of criteria there aren't on her computer. Was there an update that she made?
Yes, this is the brand new module. So Karen, if you could just let your PSO know that, and we can make sure that your specific practice is updated. This is a new module, so we may have missed 1 or 2 practices in adding them into this. But we do hope that moving forward, and particularly as the population of our region particularly ages, that this really provides assistance to all practices and all practice staff in the management of their patients. And also this would also be inclusive of those patients living in aged care facilities that are on the practice books. So they would be included in these numbers too. Any other questions for the aged care module? No worries. And lucky last that I'll go through is, and very brief, is we previously used to have just an Aboriginal medical service module that was just available to our Aboriginal medical services and community controlled health organisations. And it was really just a breakdown on a population level of their active patients, of those that had had their health assessments based on the different age groups of 0 to 4, 25 to 54, 55 plus, those that are 50 plus having their flu vaccine, those with diabetes having their HbA1c recorded in the last 6 months, having their estimated glomerular filtration rates and ACR in the last 6 months, blood pressure in the last 6 months, and again, the eye and the foot exam occurring in the last 24 and 12 months respectively. So we've had conversations with the practice support team, and Karen, this may be the situation for you, but we are in the process of opening this module up to all practices. I'm acknowledging that all practices do have, Aboriginal clients on the book, and likewise, they should be having those conversations about those health assessments or those 715s, which are completely billable for those patients. So I guess what I've done so far with everyone is provided a very brief synopsis here of the updates that we've undertaken for the primary health information platform. And the 2 key phases that we've had with this is one, as a part of that practice incentive payment program, or PIP QI, and making sure that to support practices in their ability to design their continuous improvement programs, having the snapshot available. So moving forward, as I said, potentially each practice can go backwards, look at any indicator, and potentially be going back up to 18 months ago and seeing how you progressed over time with your indicators. And so I really hope that that really helps each of the practices that have signed up to the PIP QI program, support them with their quality improvement programs. And as I said, the second phase of this was really about moving the primary health information platform from just providing information on processes that have been undertaken in regards to clinical management, as opposed to those outcomes. And I really would like to hope optimistically, particularly for the practitioners that are available today that have been in attendance, that this is something you can have a look at moving forward and engage with regularly, at least once a month. So it's the 15th of each month that we receive your data, and obviously the following month we'll update it accordingly. So it is static on the primary health information platform. So when you do sit down with your practice support officers, and for example, in diabetes, you're looking at those patients that have had their BMI recorded in the last 2 years, because that's a static date, if you pull the data, it may vary slightly with the practice support officers. And that's just something to be aware of, and that's just that limitation with the primary health information platform, that we're just taking a once-a-month snapshot of the data that we receive once a month. Whereas when the practice support officers are sitting in your practice, you've got live data in your system that you're using, and so that's going to have slight variation. Have people actually generally used primary health information platform before, and has anyone found this particularly to be useful or insightful? Because I'd really love to get everyone's feedback that's been attending today in particular on this one, and I really want to make sure that, you know, the data team in particular can deliver a product that really supports every practice in how you manage your patients and how you can identify funding opportunities and where you can improve your MBS billing of patients as well.
So we've got a comment from Gillian. I rely on the platform to guide me with how to make improvements.
That's really lovely to hear, Gillian, and I hope that these changes really help you continue that journey onwards. And if you do have some different ideas and things like that, always let our practice support officers know. It's not very easy to make changes in a big beast like this, but obviously, you know, if there are things that really come on board and there are tweaks that we can make, then that's something that we can try and do. But we do rely on a third-party provider to support us with the development of this platform, so there are limitations with that. And we did make sure with the PIP QI module that when the Australian Institute of Health Welfare changed the criteria for numbers 8 and 10 2 months ago, that we've updated it already accordingly so it matches.
And we've got a comment from Karen. It's great information to take back to the doctor and staff to make improvements. And what's really nice is when you look at it and realise that you're doing okay.
Yeah, and look, there are some really great achievements across the PHN, and as I said, we've really tried to go into the positive behaviour territory, because we know, you know, no one wants to be told that things are being done wrong or you're not doing this. We really wanted to celebrate where people are doing really well, and that's the focus we've taken with this. So I'm really happy that with that feedback, Karen, and I'm really happy that that's really constructive for you and your practice as well.
So a comment from Therese, the updated platform looks great. Daniel, thank you for an excellent overview.
No worries. This will be recorded, and I have spoken with the continuing professional development team, and they have added an extra question to the evaluation after this session about potential future data needs. And so just to let you all know, my background is as a public health epidemiologist. I previously worked at the local health district managing the epidemiology research evaluation team, and based on some of the feedback that I've had from the Far West and Western clinical councils, there seemed to be from some of the practitioners around a bit of an appetite with support about the interpretation and the reading of data in particular, as one of the practitioners had mentioned to me that once upon a time ago there was no data, now there's a flood of data and you don't know what's the data you need to look at and what's the data that's important. So when you look at that question, really have a good think about what that means for you and how we as a PHN can support you in particular moving forward. And I'm happy to answer any questions through the PSOs that you may have as well. And I really do want to just reiterate that link of the practice support officers. They're a fabulous team, and they do regularly go out at least once every 2 months to each of the practices, COVID bearing. So do touch base with them. If you don't have access or you need to register your access to the Primary Health Information Platform, do let them know, because you will need to you will need to fill in a consent form. And the reason why you're filling in a consent form is because, yes, you are getting to look at your own data, but you're also actually getting to see the aggregate cohort data as well as that comparator. So if you recall, I had here at the very beginning where you can see on the right-hand side where you've got that cohort. So each of the data sharing agreements that we have with our practices, we take those very seriously. Everything is de-identified. No one can tell which practice is what. They're all coded there. I've even removed the codes from this so that I could uber protect this particular practice that I took this screenshot from. And so I've also hidden out all of these indicators here so that no one can actually identify it. We do take it very seriously at the PHN data governance, and so that's why you sign those data consent forms as a part of getting access to this system, so that you're cognizant that if you're wanting to report on your own purposes and you're wanting to compare to the cohort, that covers you for accessing and being able to see that cohort data.
Does anyone else have any other questions or comments to make? Daniel, is there anything else you wanted to cover off on?
No, I think that's about all. I really want to thank everyone for their time. I know that working in general practice is a very busy and hectic environment, but I really hope that you get a lot out of Primary Health Information Platform. And if there are colleagues that haven't been able to make it today or won't be able to make it tomorrow, there will be a webinar available. And again, please contact your PSOs, and we can always look at running another one of these sessions again, because I really want to make sure that people are comfortable with it and feel comfortable in interpreting the data as well.
So if that's all from you, Daniel, I'll just quickly put up a QR code for people to scan to access evaluation. And yes, Karen, I'll pass on your details to Michelle. If you can just use your phone to take a scan of that QR code, it'll take you to our evaluation page, and we'd love your feedback on this afternoon session. There is another session tomorrow night from 7:30 to 8:30, which hopefully a few more GPs may be able to come to that as well. So we look forward to talking to you again tomorrow night. Thanks for being here today, and take care. Thanks, Daniel.
Thank you, and thank you everyone for your time.